I'm Michael Narvey, neonatologist from Winnipeg, Manitoba, and what we're going to talk about is management of early neonatal sepsis. For information about me, please take a look at my bio below. The objectives of this presentation consist of three parts. We are going to go through two case reviews, and from that, try to learn a few key points about the management and investigation of neonatal sepsis. We are going to apply the current CPS statement related to newborn infection to the cases, and we're going to finish after presenting the evidence, showing you some take-home messages to think about bringing into your own practice. It's important to begin with some definitions. When we talk about early onset neonatal sepsis, we are referring to infections that occur within the first 7 days of life. The reality is that the majority of these infections occur in the first 24 hours of life. And furthermore, most of these infections represent vertical transmission. In other words, these are infections that have occurred from infection that has come from a mother. These are related to birth, and these are not hospital acquired. Late onset neonatal sepsis, in contrast, occurs after 7 days of age and is commonly thought to occur related to nosocomial reasons. In other words, acquired from a poor hand hygiene, acquired from central indwelling catheters, and these are not related to birth of the infant or received from the mother. Let's begin with case 1. This is a 26-year-old G1 P0 mother who is hepatitis B, HIV, chlamydia, gonorrhea, and GBS negative. Her pregnancy was complicated by gestational diabetes mellitus and pregnancy-induced hypertension, both of which were well controlled. This was a spontaneous vaginal delivery at 37 weeks and 6 days, and the birth weight of this infant was 3,380 grams. APGAR scores were 9 at 1 minute and 9 at 5 minutes, reflecting a vigorous and well-appearing infant. The baby was in the normal nursery with his mother and was breastfeeding. At 36 hours of age, though, this infant presented with abnormal movements. These movements consisted of lip smacking, limb cycling, and tonic-clonic movements. The differential diagnosis for this presentation would include pneumonia, sepsis, and finally meningitis with respect to infectious causes. Meningitis is put in bold, as given the neurological presentation, this is most common. However, there could be concurrent sepsis and pneumonia or pneumonia with this sort of presentation. The treatment with antibiotics would be based on the presence of meningitis in terms of length of treatment, which would be the longest form of treatment. But we also need to consider that the presentation of seizures may not reflect an infectious cause. Seizures could, of course, be meningitis, but we also must think about viral encephalitis or encephalitis from an inborn error of metabolism. And finally, neonatal stroke, which has become an increasingly recognized cause of neonatal seizures, and in an otherwise well-appearing baby may actually represent a higher likelihood of causes for seizures in this period. Faced with a patient like this, you would need to consider what workup you would do. A CBC and differential, as long as blood cultures, should be drawn given this presentation. I have put there ×2, indicating we would want 2 blood cultures, and the reason for this will be shown in the following slide. Some centers would think about doing a CRP, others would think about drawing a urine culture, and of course, you would likely want a lumbar puncture given the presentation. The treatment, of course, would be antibiotics, given that we are believing that this is a case of meningitis. We would also need, aside from the possibility of infection, neuroimaging to determine what the brain appears like under these circumstances, and also to help with diagnosing other things on our list for the differential diagnosis. With respect to performing two blood cultures, an important study that looks at this practice was published in 2017 by Tomar. One of the challenges that we have when we only draw one blood culture is that how do you know if that's a true bacterial infection or a contaminant? Now, certain infections will lead you to conclude it's a true infection, such as if you get a significant pathogen like E. coli or Enterobacter. But what do you do when you get coagulase negative Staphylococcus? This was highlighted in this paper that enrolled 475 neonates. On the far left, you can see that there were 254 babies who had a first and second culture sterile. However, there were a significant number. There were 91 patients who had a first or second culture that were positive, with the other culture being negative. What wound up happening was they realized that a significant number of these patients in the middle group actually represented contamination. And finally, when the first and second culture were both positive, that occurred in 155. When you look at the accuracy of picking up infection, this represented an increase on average of 7.6%, with a 95% confidence interval of as low as 2.41%, but as high as 12.79%. So the evidence which suggests that if you are wanting to accurately diagnose a bacterial infection in a neonate, one should draw two cultures in the initial workup. After the initial workup, and if you have two positives, you may elect to repeat a single culture in follow-up. I have the pleasure of being the chair of the Canadian Pediatric Society Fetus and Newborn Committee and have served on the committee since approximately 2015 in one capacity or another. We published this statement back in 2017, Management of Term Infants at Increased Risk for Early Onset Bacterial Sepsis. And in this statement, we addressed the question of what to do about the lumbar puncture. Now, there is a fair bit of consternation that occurs. People don't want to hurt babies. They don't want to do unnecessary tests. So if the yield is going to be exceedingly low, should we be doing an LP? Well, let's take a look in the next couple slides at what the CPS says about this. When considering doing a lumbar puncture, these are some of the points that we outline in the statement. First of all, meningitis is very uncommon in newly born infants. There's an incidence of only 0.25 to 1 per thousand live births. In asymptomatic term infants investigated for early onset sepsis, no cases of meningitis were reported in 3 large observational studies. So this is a very rare event. So do I, for example, do a lumbar puncture in babies in the case room or delivery suite? Generally not. But for any baby that presents later on, in the first day or second day of life, I do an LP. Meningitis, though, was similarly very uncommon in preterm infants investigated for early onset sepsis, where the primary presentation is respiratory distress. So think there about babies with transient tachypnea of the newborn or children with RDS. Are they likely to have meningitis? The answer is no. However, newborns with a positive blood culture are likely to have meningitis. Therefore, especially in the presence of a positive blood culture, if you haven't already done the lumbar puncture, I would recommend that you get one done. Complicating this story is the fact that between 8 to 40% of those infants who have early onset meningitis actually have a negative blood culture. So the practice of saying that we'll do the blood culture and if it's positive means you will miss some patients if you take that approach. Therefore, an LP should be performed at the outset when there is a strong suspicion of early onset sepsis or when signs of meningitis are present. In term infants, CSF and white blood cell counts of over 20 to 25 would be considered abnormal. And it's also important to recognize that you can have a normal CSF white blood cell count and have meningitis. The reason for this is twofold. Some organisms, even GBS, may not lead to a robust cellular immune response at the beginning, or you may have also caught the infection very early and therefore missed the period where the white cell count may be headed upwards. I alluded earlier to the question of the CRP in early onset sepsis. Many years ago, about 10 to 15 years ago, this was a very hot topic. And many studies were done, as you can see in the systematic review by Brown. When you put all the studies together, though, and you look on the far right of this curve, or this figure, and you look at sensitivity and specificity, you see that the sensitivity and specificity are all over the map. It's not a great test, and therefore generally not recommended as part of the early onset sepsis workup. From the same set of results, the authors put together a receiver operator curve. The line at 45 degrees represents a very unspecific or sensitive test, really there being no relationship or no effect of the test. The curved line represents how sensitive this test actually is. And the more that line is shifted towards the left y-axis, the greater the sensitivity. And as you can see, this test is simply not sensitive. There are many reasons for this, which we'll discuss in the next slide. The problem with the early CRP assessment is that there are many factors that can raise the CRP that have nothing to do with sepsis, which is what leads to it having such a high false positive rate. Things like perinatal asphyxia, simply having maternal fever, prolonged rupture of membranes, even a long labor, stressful delivery for the fetus, even silent meconium aspiration. Surfactant application for a preemie can raise your CRP. Having an intraventricular hemorrhage, pneumothorax, or tissue injury. All of these things can elevate your CRP, and for that reason, simply do not make this a good test that I can recommend as part of the early workup for neonatal sepsis. Now, what about antibiotics? I think anyone would say that we should use antibiotics in this situation. However, what you're going to use depends on a few factors. One thing that I've learned as I've had the pleasure of presenting and going to different places in the world is that the predominant bacteria causing early onset sepsis vary by geographic location. So you really need to know what bugs you're trying to treat where you are. You also need to determine whether this is sepsis or meningitis. Do you need CSF penetration or not? If you do need CSF penetration, the recommendation would be to use a third-generation cephalosporin. Otherwise, in North America, where we consider group B strep, E. coli, and listeria the three most common organisms that cause neonatal sepsis, ampicillin and gentamicin will cover all of these. But again, you need to know what the distribution of bacteria is in your country, and you also need to know what the levels of resistance are against common antibiotics that are used in your institution, against bacteria in your institution. So at the end of the day, what was found? The CBC, blood culture, CRP, LP, viral workups, urinary culture, and imaging were all done. The lab results revealed 2 blood cultures, both positive for group B strep, a CSF protein elevated at 3.75, and a glucose of 0.9. The cell count was 5792, and the CSF cultured positive for GBS. So this was a classic presentation of GBS meningitis, leading to neonatal seizures. Now let's discuss case 2. This mother was 30 years old, a G2P1 with a dichorionic diamniotic twin pregnancy. She was hepatitis B, HIV, chlamydia, and gonorrhea negative, and her GBS status in this case was unknown. She did not have gestational diabetes or pregnancy-induced hypertension. She had no fever. She had preterm premature rupture of membranes for 2 days, and she was treated with 2 doses of penicillin G prior to delivery. She delivered at 28 weeks, 6 days, and twin A had a birth weight of 1380 grams and an APGAR of 1, 7, and 8 at 1, 5, and 10 minutes, respectively. So this twin was initially given positive pressure ventilation for the first minute and then transitioned on to CPAP of +6. As part of the usual workup in our institution, this infant was given a caffeine load of 10 milligrams per kilogram of caffeine base, and by the second day of life was on CPAP and on room air. From an infectious standpoint, the first blood culture drawn on the first day of life was negative at 48 hours, and so ampicillin and gentamicin were DC'd after 2 days. On the 5th day of life, there was increased work of breathing, apneas and bradycardias. The infant was lethargic with partially digested residuals and hyperglycemia. What about the differential diagnosis? With a presentation like this, apnea, new onset, I would be thinking about infection, including sepsis, pneumonia, meningitis, possibly necrotized enterocolitis, although it's a little early for that. The investigation would include a blood gas, a CBC, a CRP, a blood culture, a urine culture, an LP, a chest x-ray, and abdominal x-ray. You'll note that I put the urine culture in bold, and that's because I'd like to talk to you about that for a minute. This is a study from 1979 that looked at whether patients with early onset sepsis in a neonatal unit are likely to have a positive urinary tract infection. So when they looked at these babies with early onset infection versus late onset infection, they found an incidence in the first 72 hours of 1.6% having a positive urine culture, and in late onset, which was after using that definition of 72 hours, they found 7.4% had a positive urine culture. This is one of the studies that led to the belief that we shouldn't be doing a urine culture in the first 3 days of life, as the urinary tract is generally sterile. Now, you could say that there were still 3 out of the 188 total cultures taken. However, when we look at how these cultures were taken, one of them was by a suprapubic aspirate, which we would believe, but the others were either cath or bag specimens. And how do those really pair up in terms of quality and reliability when we compare it to a suprapubic aspirate? So in early onset sepsis, we don't think that performing a urinary culture is really of that great benefit based on the 1979 study in terms of percentage that would have a positive. But maybe in those few that are positive, it might make a difference to care. And that was the question that Riskin et al. Asked in their paper from 2013. Their control group consisted of 182 babies who had septic workups. Some of them had urinary cultures sent, some of them didn't. It wasn't standard of care. In the study group of 173 patients, what they did in the study was they said all babies had to have either a suprapubic aspirate or a catheter sample taken. And they wanted to see what the care was like between the different groups. What they found, not surprisingly, was there were very, very few positive urinary tract infections. So in the control group, they found 1.1%, and in the in the study group, they found 0.94%. There was no difference. Importantly, when you looked at the incidence of positive blood culture, it was also no different. 2.2% in control, 1.73% in the study group. In essence, knowing that there was an organism in the urine didn't affect the number of positive patients with a blood culture, nor did it seem when they looked at it to really impact the clinical care that was provided. Therefore, this adds to the strength that maybe we don't need to do the urine culture in the first 72 hours. Now, if you're going to do a urinary specimen, the way you collect it matters. There's a perception by many that use of a urinary catheter for collection of a urine specimen is less invasive and a better choice than a suprapubic aspirate, which could be painful. But a study of 105 infants with urine culture that was sent by both urinary catheterization and suprapubic aspirate gives us some very interesting answers to this question. The left side of this slide shows you what happened from all of the 105 samples that were taken. Shockingly though, only 24 samples by suprapubic aspirate were positive out of 105 urinary catheter samples that tested positive. What that meant was that diagnosis of urinary tract infection had a 71.1% false positive rate when collected by urinary catheter samples. Now, while you might say that this would be more painful to have an SPA, the reality is you're trading a little bit of discomfort for a higher use of antibiotics, and we all know that that can affect the microbiome of the infants in a very adverse way. But that's the subject of a talk for another time. The blood work revealed a respiratory acidosis. The chest x-ray was fairly benign, although low lung volumes. Abdominal x-rays did not reveal necrotized enterocolitis, and a CBC had a white count of 14, a hemoglobin of 79, a platelet count of 123, and a CRP of 20. The CSF was also clear. This was a case of GBS sepsis with a CSF culture that is negative. This is the NEOPIN study from 2017. It's been shown in children and adults that the use of procalcitonin may reduce antibiotic duration in patients with severe sepsis. There have been standards or reference ranges that have been made for procalcitonin in the neonate, and therefore the authors of this study sought to determine whether they could replicate some of the literature or findings from children and adults and see would the use of procalcitonin reduce antibiotic use. The timeline of the study is shown, and for reasons of time allowance, I will let you read through this, except to say there were repeated measures of procalcitonin in patients who were either category 3 or category 4, where there was unlikely occurrence of infection or infection was possible. So this was to help the people in the study determine where you didn't have a high likelihood of sepsis, should you really continue the antibiotics or not. By neonatal standards, this was a very large study, 866 infants in the procalcitonin group versus 844 in the standard group. But the median difference found was minus 9.9 hours of antibiotic duration when procalcitonin was used. This was 55.1 hours versus 65 hours. And this was statistically significant. However, I have to ask, was this statistical significance really clinically significant? Is a shorter duration of antibiotics by 9 hours really worth it? Something for you to think about. One concerning feature from this study was that while there were no differences in rates of reinfections of antibiotics between the two groups, which of course would suggest that using procalcitonin to stop antibiotics early doesn't lead to an increased rate of reinfection. However, although the rate of prolongation of antibiotics was 24.2% in the procalcitonin group versus only 11.2% in the control group. What this tells us is that while overall the use of antibiotics was less, there was a higher likelihood in the procalcitonin group that physicians would use that data to prolong an individual's antibiotic course. So I would say the jury is still out on whether procalcitonin is right, at least in early onset sepsis. So what have we learned today? CRP likely has a limited utility in early onset sepsis due to high false positive rates from non-infectious causes. Secondly, if you suspect a UTI, it is best to do a suprapubic aspirate. This can be improved in terms of accuracy by the use of point-of-care ultrasound. Finally, while procalcitonin may shorten median durations of antibiotic usage in early onset sepsis for neonates, it may, on an individual basis, increase the likelihood that you as a physician will find a reason to prolong an individual's antibiotic course. So use with caution.